Thank you very much, and it's a pleasure to be here, and I want to thank the organizing committee for having me speak, but more than that, Dick Raymond and others who helped put this meeting together. I was there for the first sort of group think about this meeting, and I have to take the blame or the credit, depending on how you guys view that, of pushing for this to be done in Atlanta. I thought it would be great to have all of you here, where really a mecca of public health happens in this country. We have the CDC, CARE, Emory University, the Carter Center. There's a lot of public health strategy that comes out of this city, and I sort of thought it would be really nice to have you all here. And from what I've heard from some people, most people that I've talked to, it's been a very successful endeavor to have it here in Atlanta, and certainly a lot of CDC participants have been here to able to listen and get to know all of you. And I know many of you through the years since I've worked in this area for a couple decades now, and certainly I think this meeting, at least so far for me, has been one of the most open and communicative meetings that I've been to, as we've all sort of been dealing with this issue for quite some time now. So I'm going to talk pretty short, brief. I got a bunch of slides, but I see we're a little behind, so I'm going to try to speed up a little. I hope you don't mind, just to try to get Jim Hughes on the stage and have him help close the meeting. I'm focusing on the international activities. There's been some splatterings of stuff about international activities throughout many of the talks, so I'm going to focus this. There's a lot that happens internationally. I'm going to focus this mainly on things that the CDC is involved in, either directly or indirectly, since that's really the stuff that I know. To start with a quote from our director, Tom Frieden, who I'm sure would have loved to have been here to open the meeting. We are all connected by the food we eat, the water we drink, and the air we breathe, and clearly this is something that we take very seriously at the CDC, and that's why international efforts are so important for us. Clearly, antimicrobial resistance is not a problem that knows borders. It's a global problem, and it requires a global approach, and that's been our take on this from the beginning. People, animals, food move around the world, as we all know. So antimicrobial resistance in any country is of a global concern. To better understand, obviously, the problem and effectively address it, we need global surveillance. We need international data sharing and harmonization and international cooperation, and these are the things that we're working toward. And you can see here, one of the assistant directors at the WHO used to work at CDC, Keiji Fukuda, said, without urgent coordinated action by many stakeholders, the world is headed for a post-antibiotic era in which common infections and minor injuries, which have been treatable for decades, can once again kill. I think you heard that I still see patients at the VA hospital here in Atlanta, and not long ago saw someone with one of those infections where you have no antibiotics left to treat. And it's still something that you wake up in the morning thinking about because you don't know what to do. You throw lots of things at them, nothing works. And it's very, very depressing in medicine, certainly, and in veterinary medicine when you have these cases where you feel like you can do nothing. So certainly it touches us all. Obviously, we at CDC work with NARMS, with our other federal partners, and so within NARMS surveillance is where we start seeing some of the international connections, and these are just some examples. Quinolone-resistant Salmonella Enteritidis associated with travel, recent publication on that. Cipro-resistant Salmonella Kentucky in international travelers and foreign visitors, and I'll talk for a second about the Salmonella Kentucky story, which is interesting. And we've described other resistant infections acquired abroad in several earlier studies, including non-typhi Salmonella with ESBLs, plasmid-mediated quinolone resistance, and finally quinolone resistance in typhoid-like Salmonella. If you consider Canada an international partner, here's the story of Salmonella Heidelberg in Quebec. You probably heard about this already, but again, another fascinating story about ceftiofur resistance and ceftiofur use. And certainly this border we touch, and so things happening in Canada affect us, and obviously quite quite close as being our neighbor. Other examples around the world, and again, there are many, many. I'm just throwing out some. Campylobacter in Europe with Cipro resistance in 52% of the strains in humans, around the same in poultry, and 80% from international travelers. Typhimurium and Enteritidis in Eastern Africa, big problems, more hospital-associated, mega resistance, lots of mortality, unfortunately. There's been a story in Taiwan that many of you have probably heard of with Choleraesuis. Infections increased in the 90s, up to 60% resistant to Cipro, and even some to ceftriaxone with the CMY2. Highly invasive, presenting even to affect the aorta, shock, and related to epizootic in pigs with the same organism. The Salmonello Kentucky story, which I just have one slide on, is a fascinating one. In the 60s, Pasteur Institute in Paris started tracking Salmonello Kentucky. They saw firstly infections in travelers from Tunisia, Africa, Northern Africa, Egypt, then in the 2000s from India, a progressive increase in resistance since the 90s. In 2008, it appeared in Polish turkey flocks, meat, and consumers in Poland. Since then, turkey flocks and meat in Germany and France, and it's one genetic lineage. It's resistant to, as you can see, many drugs, and even sometimes has the CMY2, which is which is the third generation cephalosporin resistance gene. So it tracked from Africa into Asia and now into Europe, and again, just to illustrate the fact that resistance has no boundaries, and I think we all know that. There have been a lot of activity at WHO with partners, all of us involved through the years. These are just some selective meetings and consultations that you can see here. I won't go through all of those. I think many of them have been mentioned. And the reason I put this as pre-2008, you'll notice the last three here are FAO, OIE, WHO meetings. So the three big UN agencies involved, which I think is really important to address these issues. In 2008, we formed a group called AGISAR, the WHO Advisory Group on Integrated Surveillance of Antimicrobial Resistance. We had sort of talked about this for a couple years before that and finally formalized it in 2008, and it provides expert advice to WHO on a couple issues: containing food-related antimicrobial resistance and promoting the concept of integrated surveillance, which essentially is what NARMS has been doing for years and is CIPARS in Canada, etc. It's integrated surveillance is the key, and the participants include physicians, microbiologists, veterinarians, epidemiologists. All 6 WHO regions are represented, and of course FAO, OIE, ECDC, EFSA, Food Safety Organization in Europe, and then NARM scientists from CDC, FDA, and USDA have participated and continue to participate in AGISAR. There are subcommittees that deal with specific issues: antimicrobial resistance surveillance, monitoring, capacity building, and pilot projects. I think one of the key areas, data management, risk communication. You've heard about all these things related to domestic plans. Well, they obviously are going to be similar internationally. The terms of reference, just briefly: capacity building activities, design integrated surveillance pilot projects, work on the WHO list of critically important antimicrobials, which I think you've heard about a little bit, and then implementation of the joint UN agency activities, FAO, OIE, WHO. Some of the key AGISAR activities involve WHO capacity building activities, so to be able to do surveillance, detect outbreaks, detect AMR, maintain this list of critically important antimicrobials and keep it as modern and up-to-date as possible, and then finally develop guidelines for integrated surveillance. And just to give you an example of some national programs and pilot projects, you can see some of the areas. Projects over the last couple of years have been in Africa, Asia, Europe, Middle East, and Latin America, so really spanning the globe and in a variety of ways. And what we found working through the years globally in food safety and now in AMR is that if you target regions, it is very, very challenging, and it is very challenging to follow up. Whereas if you target individual countries, work with a country, oftentimes you inspire the neighbors because the neighbors want to compete and they want to do what other countries are doing. And so we're focusing now a lot more efforts on pilot projects and individual national strategies than sort of a regional strategy, which is what we did for many years. And we did that with this group, Global Foodborne Infections Network. It used to be called WHO Global SalmServe. Many of you have heard about it, worked with us through the years, and now we use this Global Foodborne Infections Network to reach out to many of these countries where we've been working now for many years and focus them in on the AMR aspects of foodborne disease surveillance. You can see FDA and CDC have been involved and were instrumental in starting that organization. It is now really a WHO group that works with many, many, many partners. We heard about this list of critically important antibiotics, first developed in 2005. I think I was on that original group. It's been revised a couple times since, and now AGISAR has really sort of taken over revising that, intended to help preserve the effectiveness. You guys have heard about this, and to help prioritize risk assessment strategies and risk management strategies. And the ranking here is a bit different than the FDA guidance. Here we're doing critically important, highly important, and important, and you can see the high priority agents. And one of the things that may be a little different in this, and I'm sure has been up for some discussion these last couple of days, is it recommends that classes not currently used in food animals, such as carbapenems, and any new class developed for human therapy should not be used in animals or plants. OIE, you heard already today, or no, I think we heard this on the first day, put out their own list of veterinary importance for antimicrobial agents, standards on prudent use, standards on monitoring, use and resistance, and held the first global conference on prudent use antimicrobials in veterinary medicine a couple years ago, actually last year. It's not 2015 yet, but AGISAR worked to put out this guidance on integrated surveillance for antimicrobial resistance. Important output was this 5-year strategic framework for AGISAR, and I think that this was something that will really be instrumental in helping nations build this sort of integrated surveillance. And you can see that NARM scientists again participated, both from all three agencies, CDC, FDA, and USDA. Some recent activities at WHO related to AR. World Health Day had a focus on AR several years ago. Reports also published, the threat of AR, options for action, and just recently this year, the first time a global report on AR surveillance, which we all participated in, giving them information. Resolution, which we heard about a little bit about at the World Health Assembly this year, urged governments to strengthen national actions and international collaboration to address resistance. And then WHO launched an online consultation on this draft of their global action plan that came out in April and got people to comment, I think many people to comment on how this report looked and how it could be improved. Clearly important is the 3 UN agencies collaborating together, and this collaboration has been established now formally to enhance global coordination of activities. Antimicrobial resistance was identified as one of 3 priority topics for joint action. Clearly, we already know it's a complex problem, and that's why we're here. In Europe, tackling antibiotic resistance from a food safety perspective, published a WHO regional office report in Europe in 2011, talked about the problems, options for prevention, and this document was primarily intended for policymakers and people working in public health, agriculture, food production, and veterinary sectors. And then finally, and I'm again apologize for going fast, but finally the TAPFAR. You may have heard of the Transatlantic Task Force on Antimicrobial Resistance. This group was constituted in 2009 with the goal of improving cooperation between U.S. and the EU on antimicrobial resistance. 3 key areas: appropriate therapeutic use of antimicrobial drugs in both medical and veterinary communities, prevention of healthcare and community-associated drug-resistant infections, and strategies for improving the pipeline of new antimicrobial agents. They identified and adopted 17 recommendations, again, some of which deal with the veterinary issues. And this has been implemented mainly through increased communications, teleconferences, meetings, workshops, a lot of exchange of information and approaches, best practices and methodologies, and this is an ongoing effort that continues between us and Europe. So to end, antimicrobial resistance is a complex global problem, and we need to have a global approach, a multi-sectoral global approach, and I think we're set up to do that. I think we are doing that now, and we're certainly engaging this more multi-sectoral and global than we ever have. WHO and other international agencies are really prioritizing this and trying to address it, and we here in the U.S. are obviously working very closely with international partners to build capacity so we can monitor and identify resistance, investigate it, and finally harmonize resistance testing and reporting so we can understand and facilitate the data sharing.